You've heard everything from a miracle cure to a complete waste of time. Your neighbor swears by it, but your cousin says it didn't do a thing. So, what does the actual research say? Today, I'm breaking down, in my opinion, the 5 most interesting facts about epidural steroid injections. Not opinions, anecdotes, but actual peer reviewed data. I'm Dr. Jacob Kneeman, board certified pain medicine physician, and this is Pain Explained. Okay, let's start with the big question. Do these injections actually work? Let's set aside personal experience for a minute. A 2024 systematic review analyzed 18 randomized controlled trials with over 2,000 patients, and here's what they found. At 6 weeks post-injection, patients reported a significant reduction in leg pain. We're talking an 8.6-point improvement on a 100-point scale compared to placebo. What does that mean exactly? It just means that patients were really feeling a difference. And at 3 months, still showing benefit. A 2021 European meta-analysis found similar results. At the 6-week mark, epidural steroid injections were superior to placebo for both leg pain and functional improvement. But, and this is important, by 6 months, the difference gets smaller. And the researchers noted that while the results were still statistically significant, they didn't always translate to meaningful, real-life improvements by that point in time. In other words, the positive effects are measurable, the results are reproducible, and they show up consistently in trials, but the results are not permanent. Think of it this way. These injections buy you a window, usually 2 to 6 weeks of meaningful relief, sometimes extending to 3 months. That window matters. It's not a cure, but it gives you time. All right, here's something else most patients never hear about. Not all steroids are created equal. There are 2 main types that we use: particulate steroids like triamcinolone and methylprednisolone, and non-particulate steroids like dexamethasone. Particulate steroids have tiny crystal particles suspended in the solution. They tend to provide longer lasting relief, sometimes 3 to 6 months instead of 6 to 12 weeks. But here's the problem before you get too excited. In 2007, the FDA issued a warning after reports of catastrophic complications, including paralysis and stroke, from particulate steroids accidentally entering spinal arteries. Because of this, many pain physicians now use only non-particulate steroids for cervical and higher lumbar injections, where the risk of arterial injection is much greater. A 2020 comparative study found that while particulate steroids did show slightly better duration of relief, non-particulate steroids were nearly as effective with a significantly better safety profile. Always ask your doctor which type they're using and why. It's a legitimate safety question. Now, this one's huge, and most patients don't understand it. In research, we don't just care about your 1 to 10 pain number. That number is subjective. It fluctuates. And honestly, 2 people can have the same pain level and completely different quality of life. What we really care about is function. Are you walking further, sleeping longer, getting back to work? Research tools like the Oswestry Disability Index measures things like, can you put on your socks? Can you sit through a meal? Can you lift groceries? A 2019 randomized trial looked at lumbar spinal stenosis patients. They measured this value, Oswestry Disability Index, or ODI, scores at 10 weeks and 1 year later. The group that got injections plus physical therapy had significant improvements in disability. But here's what's even more interesting. The patients who got injections alone also improved a lot. Both groups hit that, what we call, meaningful clinical difference in their day-to-day lives. Now, what about these pain scores? Yeah, they improved as well, but the functional gains, the ability to do daily activities, that's really what predicted long-term success. I tell my patients it makes a minor difference whether you're a 3 out of 10 or a 5 out of 10 on pain. I care if you can play with your grandkids. I care if you can stand long enough to cook dinner. Now, 10 out of 10 pain is important to know, but that usually means that you need to be seen in the emergency room. That's how modern pain medicine measures success, through function and abilities to do things, not just a number. And this is where modern day pain medicine research is headed, away from the pain score and towards more functional-based outcome measures. Because at the end of the day, the goal isn't zero pain, it's restored function. Let's talk about safety, because this is what keeps people up at night before their procedure. A 2011 study tracked over 4,200 X-ray guided epidural injections over 7 years. No major complications. Zero. Minor complications? Yes, about 2.4% overall. Most commonly, temporary increased pain, injection site soreness, and headache. A separate study of nearly 1,000 cervical injections under CT or X-ray guidance found a complication rate of 0.4%. All those complications were minor. Now, does that mean the risk is zero? No. Serious complications can happen, like pooling blood in the epidural space, infection, and nerve injury, but we're talking incredibly rare and very low likelihood of happening. The key is technique, where these three things matter. First, X-ray or CT guidance. We need to see exactly where that needle is going in real time. Second, contrast dye use. Before we inject anything, we typically confirm with dye that we're in the epidural space, not in a blood vessel, and not in the spinal fluid. Patients who are not deathly allergic to contrast can also take medications to temporarily suppress their immune reactions before their injections, so that way we can use contrast dye. Third, non-particulate steroids for transforaminal injections. Dexamethasone, for example, instead of particulate steroids like triamcinolone or methylprednisolone, in certain approaches reduces the risk of clotting events. A 2019 study on dexamethasone injections found an overall systemic side effect rate of just 4.8%. Things like facial flushing, temporary blood sugar elevation, but no major complications. So here's the bottom line. When done with proper technique by an experienced provider using image guidance, this is a low-risk procedure. But always confirm your provider's protocol. Ask, do you use X-ray or CT? Do you use contrast? What steroid do you usually use, and why? These injections, as I've mentioned before, are a bridge, not a cure. This is really the most important fact about these procedures, and it's where the research and clinical practice really align in my mind. Epidural steroid injections are not designed to be a standalone cure. They're simply a bridge. The 2020 Cochrane Systematic Review, which is essentially the highest quality standard of evidence in existence, concluded that epidural steroids provide short-term benefit, but long-term outcomes depend on what you do during that relief window. Think about it. You get an injection, your pain drops from an 8 to a 3. What do you do with that window? Option A, you go back to doing exactly what you were doing before, same posture, same weak core, same movement patterns. Then the pain comes back. Or option B, you use that window to restart physical therapy. You rebuild your core strength, improve hip mobility, fix your movement mechanics. The research supports option B. A 2019 trial compared injections alone versus injections plus physical therapy for spinal stenosis. Both groups improved, but the group that added physical therapy had significantly better emotional function, emotional well-being, and perception of general health at 10 weeks. Here's what I tell every patient. It turns down the inflammation, but it doesn't fix the underlying problem. You need to use that relief window strategically. Strengthen, mobilize, and retrain your body. Because that's how short-term relief becomes long-term recovery. The injection is the bridge, an important one, but physical therapy, core work, movement, that's the foundation to the other side. But here's the next question. Why does your back pain keep coming back regardless of what you try? That's what I'm covering in my next video. The top 5 reasons your back pain keeps coming back. Click right here to watch that next. And if you found this video valuable, hit the like button and subscribe to continue learning more about pain medicine topics like this every week. I'll see you in the next one.